And finally, I have the honor to introduce our dear colleague, Professor Hassanein. Professor Mohamed Hassanein is a senior consultant in endocrinology, Dubai Hospital, the United Arab Emirates. Professor Hassanein holds an academic post of senior lecturer and associate director for the postgraduate diabetes education, Cardiff University, UK, since 2007. And was appointed to the post consultant in the Department of Endocrinology in Diabetes UK since 2002. Professor Hassanein graduated from the Faculty of Medicine, Alexandria, Egypt, and it's our honor to have him in our faculty. His main research interest is in the field of diabetes and Ramadan. He co-authored recommendation papers on this subject for the American Diabetes Association 2005 and 2010, and for the British Medical Journal in 2010, and as well as the IDF DAR Practical Guideline 2016. Dr. Hassanein will inform us about the latest guidelines regarding the fasting Ramadan with the DAR. Please, Dr. Hassanein, you can start.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Professor Alia and Professor Tamer, to invite me. It's always great pleasure to be with colleagues from Alexandria. It gives me the feel of being in my beloved city, Alexandria. May Allah, inshallah, allow us to come and visit again soon. The topic of tonight is really quite important, and I'm personally quite excited about the other topics about the common endocrine causes. For diabetes and Ramadan, as you all probably would know, we've launched the latest guidelines in January, in the 21st of January, and they are available on the website of DAR or the website of the IDF, where you can download the full document. What I will do here in the short time, I cannot obviously cover the full guidelines, but I will cover some of the new points for the guidelines. So thinking of fasting for people with diabetes, I'm not really talking about benefits of fasting in general. We all know there is benefits of fasting, specifically if fasting was done properly, but other benefits for fasting for people with diabetes. Now, we all know, alhamdulillah, that Ramadan is a very, very important month for all Muslims. In fact, for all people who live in a country like Egypt. Even at the time when I was living in Egypt, my Christian friends would enjoy the atmosphere of Ramadan very much so. So it's a religious month, it's a spiritual month, it's a social month, and with all this, people are keen and looking forward to it. So mood can improve, and anxiety and stress can improve. And of course, many people do many good deeds during the month of Ramadan. But I want you to think also on the other side of the coin. I suppose all of us have seen the comedy movie of X Large, where the actor Mohamed Hilmi, or Ahmed Hilmi, I can't remember, gets terribly anxious about Ramadan starting with his diabetes and obesity and concern. And that's maybe a comedy, but the reality, there are some people who are concerned about how can they fast. The benefits have been shown in many of the recent studies. We've seen people with diabetes during Ramadan, they lose a bit of weight, their glycemic control and blood pressure and lipid parameters improve, and markers for fatty infiltration have been shown in recent studies to improve. Of course, this is not the case for everyone. Some overindulge in Ramadan food and drinks and kunafa and ataif and khushaf and all the big meals that we all remember. But I think overall, we can say that for many people with diabetes specifically, if they look after themselves, they can lose weight and can have better parameter. How does this affect the mental well-being? There's been recent studies to look into the mood and the mental well-being of people with diabetes during the month of Ramadan. And obviously, all of the physical parameters can affect the thoughts and the mind. So you need to think of the change in diet and change in physical activity. And you'd say that the benefits would be self-control, mood and feelings of anxiety or depression would improve. But the negatives is the reduced energy and feelings of lethargy, which would put the person with diabetes into greater risk because of maybe lack of physical activity. Sleep. We know that sleep is interrupted during the month of Ramadan. We wake up for suhoor for those who sleep. For some, they carry on until suhoor and then they sleep during the day. That interruption of sleep or not sleeping during the night time has an impact on many of the hormonal hormones and the circadian rhythm for many of the hormones. So we see a negative impact because of this, with still the reduced energy and the lethargy and the feelings of depression and lack of concentration. Of course, for some, the fact that they do not smoke for the hours of fasting, for those who are waiting for a push, many do indeed stop smoking during the month of Ramadan. And perhaps this could be an opportunity for lifestyle advice before Ramadan to advise your patients on smoking cessation. But when you see a patient in front of you, of course, I know that the vast majority of your patients want to fast Ramadan. And to tell them do not fast is sometimes quite difficult. But we should not generalize and take it for granted. There are some who are waiting for us as healthcare professionals to tell them clearly, in a scientific, simple, non-confrontational way, what is their own risk and whether they should fast or not. And I think in the past, we used to have the traffic light table of this group of patients are not to fast. This group of patients are okay to fast. And this group of patients is a bit of maybe. What we see in reality, we say so many patients are high risk to fast, but the fact of the matter, they do fast. So there are so many parameters that you need to think of when you decide on whether the person can fast or not. Some of them are related to the month itself. For example, what season, what's the weather like, where are you geographically, what are the social circumstances, length of hours of fasting, type of the job of the person. All of these are important factors. The other factors are related to diabetes itself. And here is the classic points: the type, the duration, the complications, the therapy itself, the proneness to hypoglycemia, whether I feel the hypoglycemia or not, and how frequent it is, access to care, do I have access to experts in the field or I don't, as well as some of the other points that are related to the individual health himself, such as their age, their occupation, pregnancy or not, meal patterns, many of the aspects. So I give you one example, for geographical differences. This is a study that we completed last year on Glargine 300 called Orion study. And this study included nearly 500 persons. 25 of them only are from Canada. The rest are from the Middle East and North Africa, as well as India and Pakistan. But when you look into the rates of hypoglycemia, you will clearly see a huge discrepancy. Nearly a quarter of the patients in Canada had hypoglycemia, while only 7 out of 477 had hypoglycemia from the other group. Well, one of the important factors is the fasting hours. But there are other factors. I recall when I was working in UK, if it's iftar time and you're still at work, you just carry on. Clinic is still on, you carry on. So what you have in your life in Alexandria or in Egypt, everything is geared for Ramadan hours. That's not necessarily the case for many people not living in similar circumstances. So that's an important point. If your patient coming to you and telling you, I'll be spending next Ramadan or the next few weeks of Ramadan in this particular place and you know that the fasting hours are long, then that's something you need to be careful of. What about type of diabetes? We've recently conducted a survey that included 8,000 persons globally. And on that survey, the number of people who fasted every single day with type 1 diabetes is only 27% versus 62% of people with type 2 diabetes. It's not only about fasting, but also about fasting safely. So when you look into how many did not have any hypoglycemia, it's only 27% in type 1 diabetes, which means 63% has or had hypoglycemia last year with type 1 diabetes from a number of countries, including Egypt. So here is the practices. You see, we haven't really changed recently, but clearly maybe because of the better understanding, the better insulins, the better monitoring, the rates of fasting for 15 days or for 30 days has improved. The Darmina trial is a trial which we've done, but it was only 136 patients. The EPIDIAR and the DAR Global Survey is much bigger, so the data is a bit more robust. But it is clear that we have a huge discrepancy from country to country. In Egypt, 65% of the cohort of type 1 diabetes fasted versus 13% in Turkey, 22% in Morocco, and 90% in Saudi Arabia. Mind you, this group of patients were obviously attending the clinics of eminent professors. So this is not necessarily the rate of fasting in a patient maybe going to a much simpler doctor with less resources and less skills and expertise. And that's really a very important factor. What about older people? Well, by virtue of their age, they would have fasting for many years. So I'm just imagining that when you say to one of your relatives, happy birthday, you're now 70 years old. And then the next sentence would be, now that you're 70 years old, you must not fast. That would be quite difficult. But it needs to be qualified of why you're saying this and whether this particular person falls in that category or not. When we look into people with older age group, and in the survey that we did, we had 1,500 persons above the age of 65. So when you compare their duration of diabetes, 72% of them had diabetes for over 10 years, which means that the likelihood of complications is much higher. And indeed, that was the case. The dark color is those with older age. And you can see that every parameter of diabetes-related complications is much higher in a person of 65 years or older. So by nature, when you see someone of the older age group, they're likely to have a number of comorbidities, plus, of course, the longer duration of diabetes and their age in general. When we look into the key parameters of the fasting, many of them decide not to fast. In fact, 29% of them decided not to fast versus 17% of those of the younger age. And more of concern is 12.4% of them required to go to emergency room or hospital admission because of hypoglycemia of the older age group, which is about double that of the younger age group. So really, this is quite important for all of us to remember. What about those with comorbidity, such as cardiovascular disease or chronic kidney disease? Well, there will be two aspects here. The first one is to ask yourself the question, does fasting make the kidney problem or the cardiac problem worse or not? And the second question would be, does the cardiac condition or the kidney condition makes fasting more difficult or not? So to answer this, we have some small data. We've conducted this study in my current hospital in Dubai, where we provided our patients with continuous glucose monitoring, with patient education, with the best insulins, and with dose adjustment. And we gave them a sensor for 2 weeks before Ramadan, as well as during Ramadan. The data that you see now is on patients with chronic kidney disease stage 3 who were before Ramadan. So 44% of them have no hypoglycemia. And another 40% or so has 1 to 5 episodes of hypoglycemia during the time of the sensor of 2 weeks. So when Ramadan starts, you see that the no hypoglycemia becomes only 27%. And you all of a sudden now see this light blue of over 10 episodes of hypoglycemia in the duration of the sensor, which is 2 weeks. So nearly daily hypoglycemia. We did not see worsening of the renal function or of the blood pressure or of any of the other parameters. What we saw in the study, which was similar to many other studies in the field, is much higher rates of hypoglycemia. The same applies to the study we did on cardiac disease, on stable patients with cardiac disease. So let's assume you have a patient that comes to your clinic tomorrow and he says to you, I had angina 5 years ago, or I had a cardiac heart attack, myocardial infarction, or acute coronary syndrome a number of years ago. So they're stable, they're not symptomatic. And equally to the kidney problems, we did not see an increase in admissions because of cardiac problems or alteration of BMI, blood pressure, HbA1c, or lipids. But what we saw is an increase in the hypoglycemia rate. 71% of the cohort had a much higher rate of hypoglycemia. How many improved? 10%. And another 19% remained the same. So these are the points that we need to think of and address. So from what I've addressed to you now is the simple example, is the glass half full or the glass half empty when it comes to the high-risk patients, the type 1, the insulin-treated, the elderly, the kidney, the cardiac, the pregnant, all of these people, you need to know that for some of them, it will be okay, and for others, it will not be okay. And because of this, we have developed a new risk score. The new risk score will be available for all of you soon as an application. You can download the document and it can be like a table, you have it in your clinic. So you put a score for the type of diabetes, the duration, the hypoglycemia awareness, severity and frequency, the type of therapy, whether multiple insulins, basal or mix or basal bolus or sulfonylurea, and what type of sulfonylurea, and so on. The glycemic control itself, whether it's good, moderate, or bad, the presence of active or stable complications, whether it's cardiac, renal, or acute complications such as DKA and HONC, and very important point, monitoring. Am I monitoring appropriately or not? And that means you will decide whether it's appropriate or not. We're not putting a number, we're leaving for you to decide on the frequency and appropriateness of the frequency. Then some of the physical and social circumstances. What is the nature of your job or your patient's job? What is the duration of the fasting? What is the mental or general health situation of the person? Are they old and living on their own or not? And of course, their own previous experience. Pregnancy is an important point because, and it's the only one with an asterisk. Pregnant and breastfeeding women, as we all know in Quran and in Sunnah, they are exempt from fasting, whether they have diabetes or not. If they insisted on fasting, then we need to look into whether they're achieving the target or not, and that will imply a score. So what you do is you apply that score and you go through it, and the beauty is, alhamdulillah, that we have the Mufti of Egypt opinion documented for that as well. If you were to ask yourself, how do they make the decision in Dar al-Ifta? Well, they have scientific professors, and we provide them with the evidence, and they have loads of discussions with us hours and hours of discussion to try to come to a verdict. They base it on two things. One is no religion advocates the harm of the body for ibadah, for doing a worship. Now, that's number one. Number two, the burden, how you feel, which is the translation from the ayah, عَلَى الَّذِينَ يُطِيقُونَهُ. So the burden of the fasting, whether it's high burden or low burden or moderate burden. So the first one is the potentials of the risk, and the second one is the burden. And at the end of the day, our job is to be safe, and that's what Islam wants from us. So based on this, a person on low score from 0 to 3, their fasting is obligatory. But if you feel, despite their score, this person needs to drink or eat more frequently because of a special medical condition, or to take medication on a regular basis, then they are exempt. The moderate group is the question mark, because we were unable to say for certain. When they kept asking us, are you certain that, or what is the probability of certainty? And we said, we're not sure. Some can yes, and some can be no. So they said, fine, okay, then they can try fasting. But if you as a physician, after careful assessment of your patient, with taking into consideration all the aspects that we've discussed, and the person's own experience, feel this person is unsafe to fast, then they should not fast, and they have a license not to fast. Equally, if they fast, it is exactly as written by the document from the Mufti. They need to comply with the recommendations and to be doing regular blood glucose monitoring. Of course, those who are high are advised against fasting completely. So, for example, insulin now becomes an important factor. Not just a patient on insulin is no. You've got figures for the insulin and a decision on how would you do this with all the other parameters. So it's not just about the insulin, it's about how frequent are the hypos? What is the control like? Are they checking or not? How long is their diabetes duration, and what type of diabetes, and so on? Because we saw from studies that we've published over the last 2 to 3 years that for patients on insulin, in gray here is during Ramadan. This is rates of hypoglycemia goes up for the person on insulin. But we have a number of studies that give us some reassurance, specifically studies on the better insulin, the more analog insulin, whether that's long-acting, short-acting, or mixed insulin. In general, they are better. I showed you the slide of the Orion study on the Glargine 300 when it compared Canada with the other world. And that has been with the very low rates of hypoglycemia. GLP-1 added to insulin has been tested in 2 studies. And of course, you know that GLP-1 receptor agonists, as a class of a drug, they have very low rates of hypos. So added to insulin will make you not need to intensify the insulin too much, plus the effect on the eating, so rates of hypoglycemia were quite lower in the study. When you look into prandial insulin, the studies have also been showing that it is good. For mixed insulin, I had the pleasure of being part of a randomized controlled trial of 263 persons on one of the new types of insulin, which is a combination of degludec with aspart and versus the Novamix 30, and the outcome for hypoglycemia was much better. And of course, we need to adjust the dose of the insulin according to whether the person take it once a day, twice a day, or 3 times a day. In general, for once a day, take it at iftar with no dose adjustment. For twice a day, reduce the suhoor dose by 20 to 50%. And give your patient an algorithm for titration, for adjusting the dose up or down according to the results. What about SGLT2 inhibitors? We know they work by causing extra excretion of urine. They can potentially make someone a bit more thirsty. Are they safe or not? Well, all of the studies I'm showing you and I'm delighted to be part of 3 of these clinical trials, that we've seen safety of the class in general. There was no higher rates of hypoglycemia, no DKA, no deterioration of renal function. Yes, patients felt more thirsty. That was true, but it did not make them stop the fast. In fact, their days of fasting was longer than the comparator. So give it to the patient as per the prescribing regulation of the drug. You do not need to adjust the dose or reduce the dose, except for the patient perhaps already on diuretics or exposed heavily to the heat and the physical job. So lastly, I want to touch quickly on education in the COVID era. I don't know how much face-to-face activities are happening in our clinics, but we need to try to communicate with our patients. And my colleagues in Egypt are prolific when it comes to the social media activity. And perhaps that's an opportunity to use the social media for education of your patients. But don't forget the education of the general public, the media people, the imams, journalists. All these people, if they pass the wrong message, the patient will believe them and not believe the doctor in the clinic. Education work, and this meta-analysis shows it is able to reduce HbA1c. And I'm delighted that we have an excellent application that includes the opinion and the videos of many experts, including my very good friends here from the faculty, patient nutrition plan, application for what to eat, advice on what to do, a fair number of very important facilities for the patient and for the healthcare professionals. We have 2 different options. So with this, my dear chairpersons, I would like to summarize that fasting the month of Ramadan is really quite important for many of our patients. They want to fast, and indeed we need to look carefully of whether we can advise them to fast or not. To do this, we need to go through a large number of important points that will make the decision individual for this particular case, rather than have a stamp, type 1 no, type 2 yes, insulin no, tablets yes. That probably wouldn't work very well. The guidelines that are available, and you can download them from the IDF website or from our website, are very practical, and they are meant to help all of us to understand and to make it safer for our patients. I thank you all, and I stop sharing my slides.